Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
Thank you. It's great to be here with you today, so thank you very much. And I agree, prevention is always the most exciting aspect of CROI. So I'm happy to review some abstracts with you today. I did try and select the abstracts that I think are the most relevant to a clinical audience. So I want to start with two studies that followed up on a finding that was presented at the International AIDS Conference in Durban last summer, and just want to give you a bit of background on that for any of you who are not familiar. So last summer, the investigators from CAPRISA reported that a tenofovir vaginal gel study showed lower efficacy in women with bacterial vaginosis, lower efficacy for preventing HIV than in women without bacterial vaginosis. And that finding brought up a lot of questions that two studies looked back at their data from PrEP studies also to follow up and report on at this CROI. So the first of these was reported by Sharon Hillier's group, where they essentially tested the hypothesis that BV-like microbiota would result in lower plasma and genital tissue levels of tenofovir. So they did a retrospective analysis of their study, which is called the FAME study. And in that study, women applied either a film or gel form of tenofovir vaginally for 6 days, came into clinic, had plasma levels of tenofovir measured, as well as vaginal swabs, applied another dose there in clinic, and had a cervical biopsy as well as plasma levels. And what they found is that women with microbiota that looked like healthy vaginal microbiota, shown on the left here, high levels of lactobacilli, had in fact higher levels with higher concentrations of healthy bacteria of tenofovir in both the vaginal fluid and in the plasma. And women with higher concentration of Gardnerella vaginalis, BV-type microbiota, had in fact lower levels of tenofovir in the plasma and in the vaginal fluid. And in fact, for the women who came in and applied it, even 2 hours later, the levels of tenofovir were lower, really suggesting that the Gardnerella were perhaps metabolizing the tenofovir. So that was unsettling, and the implications were somewhat uncertain. But there were reassuring findings presented by Renee Heffron and the Partners PrEP group, which looked back at data from the Partners PrEP study. This, of course, was the large study of serodiscordant couples that looked at oral tenofovir and tenofovir emtricitabine. And in that study, PrEP was found to be very effective in women, about 70% effective in women who had high levels of adherence. So they did a secondary analysis where they compared PrEP efficacy for preventing HIV in women with bacterial vaginosis and without bacterial vaginosis, and essentially found that PrEP was equally effective. What you see here is BV defined by the Nugent score, which is what's typically used in research, but they also looked at this, did a sensitivity analysis by defining BV a number of other ways, including quantitative PCR of Gardnerella, and found this was a very robust finding. So reassuringly, oral PrEP works to prevent HIV in women regardless of their vaginal microbiota. As Brian alluded to, there was a presentation by Elise Tung and colleagues here in Seattle on pharmacy-based PrEP, who I think you're going to hear from in May. And this got a lot of attention at this CROI, and I think also got a lot of attention at the HIV prevention conference last year. And this is a very exciting model. I have visited the pharmacy one-step PrEP here in Seattle, which you can see a picture of on the left. So Kelly Ross Pharmacy does what's called a collaborative drug treatment agreement with Dr. Peter Shallett here in Seattle. They deliver a pharmacist PrEP model where the pharmacists do everything for PrEP. They do the counseling, the assessment, the navigation to connect patients with insurance, and patients can either self-refer or be referred, and essentially the day they come in, they leave typically with a bottle of Truvada. They get their STD screening through phlebotomy from the pharmacist for their syphilis and through self-obtained swabs in the bathroom around the corner, and come back quarterly for that. So Elise and her colleagues reported on retention rate from the first year. They enrolled 373 patients, the vast majority of whom were MSM, and only 15% of whom reported having a primary care provider at the time of enrollment, showing that they really were accessing a population who likely would not have gotten PrEP through a primary care provider or elsewhere. And they had pretty good retention, 75%, which is comparable to other operational reports in the US. And impressively, 97% of their patients didn't need to pay anything out of pocket for the medications, showing how effective they were at connecting patients with payment support. I think there were two other interesting abstracts highlighting pharmacists as key HIV prevention partners. One of these was a survey in Iowa and Nebraska where there was an electronic survey sent out to all pharmacists in the state. It had a relatively low response rate, as we often expect with these type of studies. But 140 pharmacists responded to the survey about whether they were willing to provide PrEP services in a similar model to that we just described. And although many of them were not even familiar with PrEP, most of them were willing to prescribe it, in fact, called themselves somewhat likely to do so. So I think this was encouraging that in a low morbidity area where many of the pharmacists weren't even familiar with PrEP, they were interested in participating in it. And I think it tells us something about the willingness of pharmacists to do this and the likelihood that we could do pharmacy-delivered PrEP in many other areas. In a higher morbidity state, Virginia, there was an interesting abstract about pharmacy-based HIV testing. This was a health department funded initiative to do HIV testing in 32 Walgreens pharmacies. They intentionally located this in areas of higher poverty and in counties with higher proportions of Black and Latino populations. The testing was offered at all times the pharmacy was opened, but they found the majority of testing and the majority of positives were found on evenings and weekends, again, suggesting that this was getting to a population that their current testing was not getting to. The testing had a 0.8% positivity in the range of what's considered definitely acceptable for routine testing by CDC standards, and it had a much lower cost per case detected than the other health department funded community-based testing. Unfortunately, after going through those optimistic studies about PrEP delivery, there were definitely some pessimistic and concerning studies looking at racial ethnic disparities in the US. So there was a report from Atlanta and the Element study, which is based at Emory. This is a prospective observational cohort of young Black MSM who are at risk for HIV, ages 16 to 29. And in this study, the investigators really ensure that any men who are interested in PrEP have access to it. So all men who entered the study were asked if they were on PrEP, and only about 2.5% were at the start of the study. They were educated about PrEP, asked again about their interest, and the majority, in fact, were interested, 63%. Another quarter said they wanted to think about it, but were potentially interested. And then the study staff ensured that they would be connected. The study agreed to pay for the labs and the visits, and they would get their medication paid for through either Gilead patient assistance or insurance. And yet, most of the patients didn't get on PrEP. At the time of the analysis, only 28% of the subjects in the study were on it. And unfortunately, there was a 5% incidence, a very high level for a US study, over the time of the study. So this was really unfortunate and shows us the challenges even in the setting of all of those resources. And it's not just a problem in the South. San Francisco showed these data from their public health clinics. Over the period of just about a year, they enrolled 219 men in PrEP in their primary care clinics and found that Black and Latino MSM and younger MSM had significantly shorter times on PrEP. And it wasn't clear at the time they reported this how much of that was due to delays starting PrEP versus earlier drop-off, and that will hopefully be reported later. But again, is concerning that the population at higher risk for HIV seems to have disproportionate access to PrEP. One intervention that was reported by Christine Kozrapor here in Seattle showed some potential promise for increasing adherence to PrEP and retention in PrEP. This was from the STD clinic here in Seattle. This was a text message-based intervention. It was not a randomized controlled trial. This was using the WellTel platform developed by Rich Lester and colleagues in BC to encourage ART adherence in sub-Saharan Africa. This text message allows monthly check-ins that essentially say, "How are you?" automated appointment reminders, and open bidirectional texting between the PrEP coordinators and the patients. And in this opt-in system, patients who opted in fact, had significantly higher retention. So it is worth perhaps a randomized controlled trial. For a more drastic form of adherence interventions, we need to look just a few years into the future when we will likely have new forms of PrEP delivery. 2 of those were reported here. One is a biodegradable implant that is very similar to the subcutaneous implant used for contraception now, and in fact uses the same deployment device. This was tested in a small number of rabbits and unfortunately was disappointing, but this is very early in the development. The drug was released 50% faster than intended, only lasted about 2 to 3 weeks, so more work to be done there. There was also a report of a transcutaneous refillable implant in rhesus macaques. You can see what that looks like in vivo there in the radiograph. And essentially, a patient would, in theory, walk around with this and come in monthly to have this port reloaded with the medication. And in fact, in the macaques, this mechanism of delivering PrEP did result in preventive concentrations of tenofovir in the PBMCs in the serum or plasma and in rectal biopsy tissues. So that was encouraging as a new way of delivering PrEP. And finally, I'd like to finish with one abstract that turns to, again, men on PrEP, but instead looking at post-exposure prophylaxis for STIs. This was a randomized controlled trial of men who were in the IPERGAY, a European PrEP study, that randomized men who were in the open label extension arm of this trial to receive either post-exposure prophylaxis for STDs or usual care. The men who were randomized to the post-exposure prophylaxis arm were given doxycycline, 200 milligrams, to be taken once approximately 24 hours after an episode of unprotected sex, but up to 72 hours. The goal of this was to prevent chlamydia and syphilis. Most Neisseria gonorrhea in Europe are already resistant to doxycycline. And in fact, it was statistically significant. It worked. It did increase the time to first STI. There was no evidence of sexual risk compensation. Only about 7% of patients discontinued the medication due to side effects. And there was a median of 7 pills taken per month, so it wasn't every day, but the range or interquartile range was 3 to 15 pills per month. So this one had a robust discussion. I would say most people don't feel like this is ready for prime time, although some feel very strongly that it is.